Thank you very much, and good afternoon, everyone. There have been other presentations at the conference that have touched on this topic, so I've streamlined my presentation a bit, but still hoping that I'm going to provide sufficient information for those of you who were not in those sessions. So as most of you are aware, interim data from the Suppression study in Botswana showed a positive association between periconceptional use of dolutegravir and neural tube defects. There were 4 affected infants with NTDs out of 426 births, giving an estimate of about 9 per 1,000. The NTDs in this group were heterogeneous, and the association was not seen in 3 comparison groups. Efforts are ongoing in Botswana and other countries to further explore this signal. So also when these interim data came out, maybe you were wondering what is an NTD. They actually are among the most common of birth defects, affecting about 300,000 births per year worldwide. And in some countries, they're a significant contributor to infant mortality. The birth prevalence per 1,000 live births range from 0.7 to 3.0, and it differs by country depending on fortification of food staples with folic acid. NTDs are severe abnormalities of the brain and spinal cord resulting from failure of closure of the neural tube by 28 days of gestation. So this is a photo of an embryo in the process of closing the tube. The type of NTD that we see depends on which portion of the neural tube doesn't close or doesn't close properly. The most common types are anencephaly, spina bifida, and encephalocele, with the proportions in a population being about 50%, 40%, and 10% respectively. The rarer types of NTDs, craniorhachis and anencephaly, appear to be more common in areas where the NTD rate in general is much higher. And of note, some NTD experts question where anencephaly really fits in with other NTDs. The 4 NTDs in the DTG exposed group in Botswana were diverse and classified, one each of anencephaly, spina bifida, nasal encephalocele, and anencephaly. So a common consideration for us when we're analyzing data on NTDs is whether to lump or split. If we look at the considerations for combining all NTD types, they are that these defects arise from failure of the embryonic neural tube to properly close. And folic acid is proven to prevent a large proportion of anencephaly and spina bifida in multiple studies, including in some clinical trials. And sparse data suggest it might reduce the risk for other NTDs, such as an encephalocele. And of course, there are always questions and concerns about power sufficient to detect a risk, and greater numbers give greater power. If we look at the considerations for splitting or separating them out, the pathogenetic mechanism of failure of neural tube closure is associated with the level of the lesion and whether the lesion is open to the environment or skin covered, which is called closed. Among the 4 NTDs in the DTG exposed group, 2 were open and 2 were closed. Causes and risk factors, both genetic and environmental, vary among and within NTD types. As an example, valproic acid most often causes a lumbosacral spina bifida. And recently, it's been shown in animal models that valproic acid disrupts a particular mechanism which closes the caudal end of the neural tube. There are other differences, as I've listed here, and we know that the same NTDs tend to recur in families. And whether this is shared genes, shared environment, or both, we may not know. So the preliminary findings represent an early signal, and further evaluation is certainly needed. However, at this time, the evidence is not sufficient to conclude a causal relationship. As stated earlier, the NTDs identified do not comprise a homogeneous group. This is not an absolute necessity, but is helpful in our considerations. Biologic plausibility is an important consideration that has not yet been worked out. The conclusions based on small numbers, and those can be very problematic. We have this problem all the time in doing birth defect studies. And we believe that full consideration of risk and benefits, as well as ethical considerations, are essential when you have early findings such as these. So a number of possibilities exist when considering this preliminary association. At the top of the list has to be folic acid and folate insufficiency. DTG might impact folate metabolism in some way to decrease folic acid available to the embryo and increase the risk for NTDs. We also know that altered glucose metabolism is a risk factor for NTDs, and hyperglycemia has been noted as a consequence of DTG treatment in some trials, usually at a lower level. There could be co-exposure with other medications or other agents known to increase the risk of NTDs. And there might be other, as yet unidentified risk factors. I must say that the collection of data in the SAPAMO study was superb. There was only one piece that we asked if it might be there, and that was family history of NTDs, because we know that family history is actually the most powerful risk factor for that condition. And of course, it could be by chance. So I'm going to get that out of the way. I didn't even notice it, sorry. How have we done, how successful have we been at teasing out these possible associations? So we have 3 examples here. Most recently, and one where the association was confirmed, was Zika virus infection and the risks for microcephaly. Many of the criteria that we use to determine whether an exposure is likely teratogenic or causing birth defects were true here. This included well-defined epi studies, biologic plausibility, and animal models. Some signals have not borne out. Lamotrigine, which is an anti-epileptic drug, is one of them. Initial data in the pregnancy registry indicated about a 6-fold increased risk of orofacial clefts, such as cleft lip and palate. With 5 more years of data, the magnitude of the association decreased by half. And then there were data from 2 independent registries and population cohort that showed rates consistent with population rates. So this is an important example illustrating how data that couldn't be appropriately combined to give a single risk estimate could be assessed for the patterns of risk. And of course, we always, in birth defects, have studies where no cause was identified. And this is true of NTD clusters in Brownsville, Texas, and Washington State, among others. So what could be the possible outcomes of investigation of DTG and NTD association? Well, the association could be confirmed. This would probably be the timeliest conclusion, that is, if we continue to find excess numbers of cases among periconceptually exposed pregnancies. And it would be important then to identify the mechanism in order to consider whether there might be ways to mitigate this risk. Accruing sufficient data to statistically refute the signal may not be possible given numbers exposed, and pulling together data from multiple sources and populations sometimes is problematic. I think further discussions are needed to decide what findings would bring us to this conclusion, that the signal is likely false, and the time involved. And of course, prolonged uncertainty is always, can always happen, and that may be where we find ourselves for some time. And risk versus benefit discussion, however, is relevant regardless of the outcomes. So considerations of risk and benefit are done every day by women working with their healthcare providers. We know that in the United States, fewer than 10% of meds have the information needed to determine risk to a pregnancy, and unfortunately that figure has not changed in the last 10 years. Many women need to take medication during pregnancy, even though some of these medications are known to increase their risk for having a child with birth defect or developmental disability. And as we've clearly heard, risk versus benefit considerations are contingent on the context. What are the circumstances of the women who may be treated? For example, is she desiring a pregnancy? And those circumstances can change over time. As a clinical geneticist, what I've experienced in 30 years of talking with women, couples, and families with concerns about environmental or genetic risk factors is that both risk and benefit are in the eyes of the beholder. What they desire from me is information to help make their decision. That includes what we know at this point in time and what we don't know. I'm sure you're all aware of the risk to a woman or a mother. I just want to conclude with the risk to the baby. There's a baseline risk of about 3% in the general population of having a baby with any major birth defect, and any additional risks, such as those with maternal age, would be added onto that. Then we would add a possible increased risk of NTDs with DTG treatment. And that Sapano study suggests that might be around 1%, but that, of course, could change. And again, the risk of mother-to-child transmission of HIV is something you're well aware of under the different treatment regimens or by switching regimens. So thank you very much for your kind attention. Please note the resources here for birth defect surveillance. They were developed through a collaboration of CDC, WHO, and the International Clearinghouse for Birth Defects. Thank you very much.
Thank you so much, Dr. Moore. Andrew Phillips is now going to present a really interesting paper on modeling future ART regimen policy in sub-Saharan Africa, accounting for drug resistance and the potential effects of DTG on NTDs. Dr. Phillips is from the University College of London. Thank you.
Thank you, Mark. So the research question that I am to address is what is predicted to be the most effective and cost-effective future ART regimen policy in sub-Saharan Africa, accounting for drug resistance and potential effects of dolutegravir and risk of neural tube defects. So the modelling approach that we've used is an individual-based model based around Southern Africa, but creating multiple potential, what we call setting scenarios, are generated through simulation. 1,000 setting scenarios are generated, as you'll see. And then various parameters relating to rates of testing, adherence, resistance, interruption of treatment, viral load monitoring, and several other factors are varied randomly within plausible bounds for settings in the region to try and to capture the variability in settings in the region. For each setting scenario, we then consider the situation now in 2018 and compare outcomes of potential policy options over the next 20 years. And then absolute numbers of health-related events, costs and DALYs relevant for a country of approximately 10 million adults in 2018 are projected. The cost-effectiveness analysis is conducted from a healthcare perspective. Costs and health outcomes are both discounted to net present values at 3%, and cost-effectiveness threshold in this baseline analysis is used of $500 per DALY averted in the base case to reflect that we think is reasonable to apply in low-income settings in sub-Saharan Africa for deciding on cost within HIV budgets. So there's a range of parameter values within the model. We capture the fact that the higher potency of dolutegravir, although we consider various degrees to which that is higher, reflecting the uncertainty in knowledge of exactly how much higher. The same with the hugely lower risk of resistance with dolutegravir, the extent we sample to capture uncertainty about the exact extent of that hugely lower risk. We also, in terms of context, consider a context in which switching to second line once someone's defined as having failure is actually occurring quite rapidly, or if, as we know in several settings, it's not occurring very rapidly. We also consider a context in which viral load monitoring is being done as WHO recommends, and other contexts in which it's virtually not being done at all because it hasn't been possible to implement it. In terms of neural tube defects in pregnant women on dolutegravir, we take the excess risk as it was before we heard the latest data yesterday from Rebecca Zash. So we take as the point estimate for the excess risk beyond what we would expect anyway of 0.82%. So we now know that's closer to 0.5% based on the extra women who have not had an NTD. And then we also consider, what if it was at the lower limit of the 95% confidence interval, what if it was at the higher level? We also consider risk of mother-to-child transmission dependent on the viral load of the mother at the time of pregnancy and birth. So then, this is just to, I won't take you through this, but this is to show you the characteristics of the modelled populations, the 1,000 of them that we recreated in 2018. And you can see that we sort of capture a range of setting scenarios which seem relevant for settings in the region with regard to HIV diagnosis, proportions of people on treatment, levels of drug resistance both before ART and in people failing ART, and several other factors. And I could have shown you, there's quite a few more, but which I'm not going to show you. So then what are the transition policy options that we're considering? So first of all, looking at the box, the first option to consider is not making any change at all to policy. So TLE, tenofovir, lamivudine, efavirenz, it would continue to be given in new initiators, those currently on first line. We'd move to ZLPI, zidovudine, lamivudine, PI for second line, and failure of TLE, move to ZLPI. And so that's what's occurring now. If we move straight to the bottom, this is a policy where TLD is used in new initiators. Everyone on first line is moved to TLD regardless of whether the viral load is measured or known. Everyone on second line is moved to TLD regardless of whether the viral load is measured or known. But if there is virologic failure detected of the TLD, then they're moved to ZLPI. And then in the middle, there's a viral load dependent shift to dolutegravir. So in those that are currently on first line, they're only shifted to dolutegravir if the viral load is currently suppressed. Same with those on second line, so that's the main difference. And then the other dimension here, of course, is to consider whether to have a differential policy such that you only use the dolutegravir in men and women who are not either wanting no more children, or they're postmenopausal and they're premenopausal but unsafe and effective contraception, versus a policy of as a default having a policy of giving it to all women, including women under 55. So to give a bit more detail about the assumptions around NTDs, so within the DALI framework that we use for cost effectiveness analyses, for a woman having a baby with an NTD, then an extra DALI, we assume death of the baby, so an extra DALI is assumed to be incurred for each subsequent year of the time horizon. We also incur at 0.2 DALIs per year for the mother for 5 years as a result of having had the baby with the NTD, but we don't assume any additional costs. For mother-to-child transmission, on the other hand, we actually make some assumptions which probably don't fully convey the negative consequences of mother-to-child transmission. This is, as I said, dependent on a mother's viral load, and we assume that if a birth of an infected child occurs, then that child incurs 0.1 DALIs for the rest of the time horizon, and there's also this extra cost because of having to treat the child. That cost is very conservatively low. Probably the DALIs is quite conservatively low, and we didn't include the 0.2 for the mother for having had a baby with an NTC with transmission to the baby. So we're actually being very conservative and really just underplaying at the moment how bad it is, mother-to-child transmission. So these are the results, the initial results, comparing the 5 strategies. So I'll just take you through them now then. And when I talk about men and women here, I mean women, the subtlety that I was talking before about which women we mean, but I'm just going to say men and women. So the comparison is stay as we are with TLE. This one is you do the TLE dependent on viral load suppression in men, but in women you continue with TLE in younger women. The next one is that TLD in men, but in TLD without the viral suppression dependence in men, but in women still TLE. Here, you for everyone, men and women, as a default, you use the viral load dependent strategy, and the bottom one here is the strategy where in men and in women you use TLD as the default, switching everyone regardless of viral load. And you can see the predicted substantial or relatively substantial predicted virologic suppression in terms of like the third 90 benefit as you go further down here, with the highest predicted virologic suppression with the strategy of TLD in men and women of all ages. If you look at, perhaps more importantly, if you look at the AIDS death rate on ART, you see really substantial predicted differences in the same direction with as you go further down with predicted mortality benefits, and this is really driven quite a lot by the fact that we know that there are currently substantial minorities of people that are on first-line treatment with efavirenz who are failing with drug resistance. As a result of a policy like this, you're actually doing that switch, which in most people is predicted to be very effective. Well, I'll come back to that. What about the adverse birth outcomes? You can see in the blue the predicted proportion of positive women, pregnant women with mother-to-child transmission, with the predicted substantial benefit as you go further down, but then you see the extent to which if this signal is true about the NTDs, the extent to which that's counteracted by the NTD signal. And as I say, remember that this is assuming 0.82 when the best estimate now is 0.657, I would say, above the baseline. So this is the overall cost effectiveness plane, taking into account costs, and that is averted on the x-axis. And you can see that all the policies are predicted to result in a reduction in cost compared with TLE. The greatest reductions in cost are with the use of TLD in men and in women, and the greatest DAL is averted is with the TLD policy. So looking at that another way, the light grey on this slide is the DAL is averted, which is what you already saw on the previous slide. The darker grey takes into account the cost as well. So it's taking into account the health benefit that you will get as a result of having reduced your cost and able to spend those costs on other healthcare. I've got two more slides, so I can't. So we considered several sensitivity analyses around all of these things listed here, sort of higher and lower values for all of these things. We sort of redid this and looked at it again. And for each of them, the TLD policy averts most DALIs and most net DALIs in each case, the most cost-effective in each case, regardless of changes in those. So the conclusions: modelling provides a means to explicitly weigh the risks and benefits of alternative treatment policies in order to inform policy decisions. Using this standard DALI framework for comparing health outcomes from a public health perspective, the results at this point suggest that the benefits of transition to TLD substantially outweigh the risks, regardless of whether the possible effect on NTD risk is real. A range of sensitivity analyses have been considered, and suggestions for further such analyses are welcome. I'd just like to acknowledge people that this has been work that's been ongoing about the dolutegravir transition well before this signal. I'd like to acknowledge the people that have been involved in this work from the start. Thank you.
Thank you so much. We've got about 5 minutes for comments or questions. Well, is there? Yes, yeah. Kevin.
Kevin de Kock, CDC. Thank you very much for both excellent presentations. I just wonder whether somebody from WHO could comment on what WHO plans to do, taking this whole discussion forward with its responsibilities.
if there is a WHO representative in the room, would you please identify yourself?
Yes, this is Martina Pinazzato, pediatric lead. So there is certainly a plan to work together with partners, and many are in the room, and to move forward with really weighing in the risk and benefits balance. Of course, we are working already with some of the partners that have presented in keeping monitoring the data that is being generated in different countries. And I think Meg presented that yesterday at the satellite. So you'll hear more for sure, and we'll certainly keep in track of everything that is happening.
I'd just like to mention a couple of other contributions to this discussion which have been made from the activist community. Polly Clayton from HIV iBase in the UK published a really important paper a month or so ago about the fact that we can't use phase 3 data from the north to develop treatment guidelines for the global HIV pandemic. And she also pointed out that it's disgraceful that we don't have more access to better data on pregnancy, on the use of ARVs in pregnancy earlier when we're rolling out really important treatments. And of course, that we don't have better access to contraception in many countries. And then the AfroCab, which is a community advisory board of African treatment activists, published a really important position paper that talked about the importance of letting women make their own decision in this case and providing them with treatment literacy and informed and empower their ability to make informed decisions about what would be best for their care, including contraception and the use of the ARV regimen of their choice. And I guess we have room for one last comment. Hello.
Yeah, thank you very much, Andrew. But somehow you fell short of making some kind of recommendations from your point of view. I mean, this topic is so important. I come from Uganda and I chair the ART committee, and we had a meeting last week. I have lots of emails to answer about DTG and whether we are continuing with it as a country for women in childbearing age, 15 to 49. And you know, we've had meetings with WHO, with PEPFAR, I mean, in the same room, people living with HIV and everyone else, you know. WHO says this and PEPFAR that, and people living with HIV, and very, very tough meetings to deal with. And of course, we are making all these conclusions based on the four cases and people reasoning that you look here, the confidence interval for those 4 cases doesn't overlap with the risk of other drugs. Therefore, we must pay attention to it. And with all of this, you know, I like your modeling and trying to see what the other potential benefits of DTG, and also considering that women of childbearing potential are heterogeneous. You know, it's not like, oh, you come and you are 30 years and I deny you DTG. I may not even, that woman may not be taking contraception, but they are not planning to get pregnant. They are not. They are not having any. So anyway,
can you give Andrew a chance to respond?
Yeah. So,
in short, I would like Andrew to make a little bit of
a policy recommendation. No. So thank you. Yeah. It's not for me, obviously, to make policy recommendations, but I'm certainly very happy to feed into discussions of policy recommendations. And I've got my own thoughts about what and some suggestions, but it's not for me to really make them public at the moment. I'd be happy to be part of any of those discussions if it would be helpful.
Ambassador?
Yeah, I think it's just important to note, and I appreciate Uganda speaking, but I will tell you in the last month and a half, from the alert that came out much more in a regulatory way rather than the public health way, countries around the globe have ordered huge amounts of TLE. So it really almost doesn't matter anymore because countries, despite the fact you said you're debating, have ordered huge stocks of TLE and will prevent the ability to move to TLD because we've spent millions and millions of dollars on a different drug, because the TLD rollout plan is not going to move forward at this pace and speed that it was going to move forward in. Now, I know that that was a conservative measure to make sure you didn't get stockouts, but I mean, there are consequences and significant consequences when we are waiting for information but move forward with decisions or move forward with concerns without the full evidence base. And the evidence base now is that we will delay and have to delay TLD rollout because the amount of TLE stocks that were purchased. And as a U.S. government taxpayer invested group, I can't throw away drugs. These decisions and these orders, I just want to make it clear, the reason we brought this up as a controversy is because you could see that there's not a complete decision yet. But by ordering TLE, we've made decisions for our clients. And I think it's just an illustration that we have to be very sensitive to what we're doing and our timing of what we do.
Thank you so much to our panelists and to the audience for their valuable contributions. Our next topic is going to be exploring some of the differences in the results of different approaches to ART scale-up in the Botswana Combination Prevention Project and the SEARCH study. And my own take on them is that they were both successful but in different ways, and they have different findings with respect to their impact on incidence and mortality. And so first we're going to hear from Jan Moore from the HIV Prevention Branch at the Center for Global Health at the CDC, followed by Maya Peterson from the University of California, who's going to talk about the SEARCH study. So over to you, Dr. Moore.
Thank you, and thank you to the organizers who brought this forth for us to discuss in this forum. Okay, I think we've heard a lot at this meeting about the rapid scale-up of universal ART and the absolute essential nature of it to reducing incidence and achieving epidemic control. As was mentioned this morning, some of you may have heard the talk by Dr. Joseph McKemma showing that we did see, with the rapid scale up of ART, we did see an effect on incidence in Botswana. 56, to be very concrete, 57 participants in the intervention arm were infected over about 30 months, while 90 in the standard of care arm. We conducted a number of analyses, adjusted and unadjusted, to look at p-values, and whatever you decide to cling to, whatever your favorite analysis was, the effect, the incidence ratio was somewhere between 62 and 70, and there was at least 30% reduction of HIV incidence in the intervention arm compared to the control arm. We also looked at coverage because we wanted to be certain that our change in incidence was associated with the change in coverage. And we, in terms of the end of the study and the cascade, we started out with estimating the number of HIV positive people in the 15 intervention communities. We were able to identify 91% of those HIV infected people. Of those that we identified, 95% were on treatment at the end of the study, and of those who were still alive at the end of the study, and except for the 3% of people that we could not find a viral load on, we had a 98% viral suppression rate, which gave us an overall coverage of 85% across the communities. Now, Botswana, as many of you know, is a country with very good coverage, and they had good coverage at the beginning of the study, but we were able to increase the first 90 by 22%, second 90 by 36%, and the third 90 by 18%. So the rest of my talk is not on the what, because you've heard that a lot, but on some of the things that we think made a difference. Now, of course, community-wide testing, whether it's home-based, mobile, targeted, RHT, was an absolute essential component of this. And I'm not going to spend a lot of time on that, because we found that even after you have identified many, many HIV positive people, that's only the door, that's only the entryway. You're not there yet. That we also needed very comprehensive linkage procedures to get people into care, and that once they were even linked to care, we needed a way of making sure that they started ART and retained on ART. And that's where I want to spend the rest of my time, talking about the second and third 90 and some strategies that we think made a difference there. Okay, I'm going to talk first about linkage and the tracking and tracing interventions that we put together to make sure that we got people that we had identified, whether they knew they were positive but not on treatment, or whether they were newly identified as positive, that we got them into care. So the first thing we did is when we identified someone in the community, we gave everybody an appointment to the local HIV clinic. And the day before their appointment, we sent them an SMS reminder. We then were able to let the clinics know who was to show up for their appointment. Because Botswana has a national unique identifier called an Omang, we were able to send Omangs to people so that the people in the clinic, so that they would know who to expect. Persons who didn't attend their clinic appointments were traced by the clinic nurse through telephone calls, and if they were not able to be contacted that way, then we had a community counselor who paid home visits. Those not linking within 90 days that we couldn't trace were linked through a national electronic medical record to determine if they had linked to the clinic outside their community. So just to show you how these procedures made a difference, we were able to link 93% of the people referred. 49% of those referred kept their first clinic appointment, and through just giving them an appointment and giving them an SMS reminder. So that's usually where we stop trying with our procedures to get people in, at about 50% linkage. But we traced individuals through home visits, through phone calls, and we were able to get another 27% of people in. And for those who still were not there, we didn't give up easily. We were able to look into the electronic medical record to find out if these were people who had linked indeed to clinics outside the local community. And we found an additional 17% there, leaving us with 7% people that we could truly call lost to follow-up. I think we use that term very loosely and very almost as if it's a good reason for why people didn't show up. Oh, they're lost to follow-up. In terms of the days to getting people into treatment, we were able to trace those at the community HIV clinics. We were not able to trace those who went to a clinic outside of their community. 64% of people linked within 0 to 7 days. We added another 18%, which gets us up to 82% after 30 days, which is what we usually look at. And then we added another 7 and 10 at 90 days and 10% over 90 days. So even though we did quite well by 30 days. I think we would still want to do somewhat better at that. The other intervention that we thought was very important is fast-tracking people once they linked. So we found that even after you get people into treatment, or into care, they don't necessarily initiate ART, and we were very concerned about that. In June 2016, Botswana moved in the middle of our study to treat all, or universal test and treat. And we used that time in conjunction with the Ministry of Health to move to ART initiation in our intervention communities. So everyone who was linked to the clinic was offered ART initiation at the first clinic if they were clinically stable. Adherence counseling, which had been 3 sessions of adherence counseling once the person reached the clinic, was done in the community when they were identified as HIV positive. Labs were drawn at the first clinic visit, but ART was not delayed, and that had been a huge delay for us. Waiting for the time that the person received and the clinic received the lab results before starting ART, many people had drifted off. Now, persons who had abnormal lab results were recalled back to the clinic. We made a very concerted effort to get them back, but that was not a very frequent occurrence. What did we see is that, again, we started in pre-fast track, which we called the group before fast track. We had 8% at the first day who started treatment, 51% in our fast track. At 1 week, and we were at 13% in fast track. In pre-fast track, 63 in fast track, and you can see on up a month we still had a big difference. By the end of the year, it was almost the same, but the time to viral suppression was 210 days for the pre-fast track and 104 days for the fast track. In conclusion, I think that we felt that the tracking and tracing procedures we had, the data systems that allowed us to track every individual from the time they were identified through viral suppression and retention, was a very important tool. Offering treatment on the same day as linkage was a very important tool, allowed us to reduce the days by 50%. I think that we feel that with these kinds of interventions, you can get to the 90-90-90 and probably to the 95-95-95 in high prevalence countries. Thank you. And I want to thank our sponsor and our funding agency, the President's Emergency Plan for AIDS Relief, for their ongoing support. Thank you.
Thank you so much, Dr. Moore.
Thanks so much for the opportunity to talk today to you about the results of the SEARCH study. In particular, I'm going to tell you about the approach we used to scale up ART initiation, viral suppression, the decline in HIV incidence we saw during the study, and the profound impacts on mortality and community health that we saw between the intervention and the control arm. So SEARCH, which was the primary results of which were presented by Diane Havler earlier today, is one of the large test and treat studies that have been conducted in sub-Saharan Africa over the last 5 years. In SEARCH, we took a slightly different approach to HIV test and treat. Rather than focus on HIV alone, we focused on HIV in conjunction with multiple diseases as part of a community health-oriented approach. We sought to test the hypothesis that this approach would reduce new HIV infections and improve community health compared to a country guideline approach. Our study design was a pair-matched cluster randomized trial. We randomized 32 communities of 10,000 individuals each in Western Uganda, Eastern Uganda, and Kenya. And the population we presented results on at this year's IS is residents that were over 15 years of age. So importantly, at baseline, in both the search intervention and the search control arm, all communities received comprehensive population-based HIV testing using a multi-disease health fair model. In the intervention communities, they also received additional annual population-based testing. All HIV-positive individuals were eligible for immediate ART, and ART was delivered using a streamlined patient-centered model. In the control communities, ART was delivered according to country guidelines. Now, importantly, about a year after the study started, country guidelines expanded to include ART eligibility for most HIV-positive persons, and these were immediately implemented in the control clinics. After 3 years, we looked at HIV endpoints, including cumulative HIV incidence, HIV testing, ART start, and HIV RNA metrics, as well as annual HIV incidence in the intervention arm. We also looked at community health outcomes, including mortality, TB, and non-communicable diseases, which today I'll focus mainly on hypertension. So first, our approach to population-based testing was highly successful. So at the start of the study, by self-report, about 57% of baseline HIV-positive individuals reported ever having been tested for HIV. After these comprehensive population-based health fair-based testing, we reached 90% of all residents of both intervention and control communities for HIV testing. This number then increased incrementally over time in the intervention arms with additional rounds of annual testing. This comprehensive baseline testing translated into dramatic improvements in viral suppression. So at the start of our study, 42% of all HIV-positive individuals were suppressed in both arms. In the intervention arm, this increased to 71% after a year, and by year 3, 79% of HIV-positive individuals were suppressed. Now, in the control arm, we don't know how fast suppression ramped up, but we do know that by year 3, viral suppression in the control arm had also increased dramatically to 68% of all HIV-positive individuals. Now, when we look at these numbers, it's important to recognize these are estimates of suppression among all HIV-positive individuals in the community. So these are not estimates among individuals who've linked to care, and they're not estimates even among individuals that we know are HIV-positive. If we look at a group of patients who are HIV-positive at the start of the study, fully 88% were suppressed by year 3 in the intervention arm and 82% in the control. These gains in viral suppression were seen across age and gender subgroups. So men at year 3 in the study, shown in the graph at the bottom, had suppression that was not as high as among women, but they still did very well, with suppression exceeding the UNAIDS 90-90-90 target of 73% in the intervention arm. Youth aged 15 to 24 also increased suppression substantially during the study, but at year 3, their suppression fell far short of that among older individuals. So clearly we have much work left to do. So these dramatic increases in viral suppression resulting from rapid ART initiation and more rapid ART initiation in the intervention arm translated to dramatic benefits in terms of community health in the intervention versus the control arm. So when we compared mortality between the arms at year 3, HIV mortality was reduced by 21% in the intervention arm. Annual TB rate in the 3rd year of the study was 59% lower in the intervention arm, and NCD control, in particular hypertension control among all prevalent hypertension, individuals with prevalent hypertension, was 26% higher in the intervention arm. Also importantly, the increase that we saw in viral suppression over the course of the study was associated with the decline in HIV incidence. So in the intervention arm of the study, HIV incidence declined by 32% during the study. And when we compared cumulative HIV incidence between the intervention and the control arms at year 3 of the study, we did not see a difference. But this was not surprising given the dramatic ramp up of viral suppression that we saw in the control arm. And this was really enabled by the comprehensive baseline HIV testing, followed by rapid adoption of expanded ART eligibility guidelines. So just to be clear, this absolutely supports that expanded ART access and increased suppression were associated with a decline in HIV incidence. It's just that this increase in suppression happened in both arms. So what have we learned from SEARCH? The first is that a multi-disease health fair-based model is embraced by the community and can successfully reach an HIV test an entire population. So what were some key components of this multi-disease health fair approach? First, it was really designed in response to the community, and the community collaborated closely in the design of these health fairs. Really in response to community requests at the start of the study, they were from the beginning multi-disease health fairs. They were not HIV health fairs, and they incorporated a wide range of services, including diabetes and hypertension screening, malaria testing and treatment, deworming and vitamin A for children, among many others. They were also held, obviously, out of facility and at times and places that were responsive to community needs. We've also learned that using this model, we can successfully reach and test both men and youth. So HIV testing coverage was high across the population. It was also very high among men and youth. So we reached 90% of all youth in the community and 86% of all men in the community through our baseline testing. So how was this accomplished? Through a range of men and youth-specific mobilizations and services provided. So in particular, the community health campaigns were held at times and places that were convenient to men as well, including at nighttime and on beaches. We also incorporated non-health related attractions into the campaigns, such as football matches and boat races. There were a number of services in the campaigns that were of particular attraction to men, and these included a men's health tent, where men could have questions answered about sexual partner concerns or STIs, an urgent care station, which had higher demand from men, NCD screenings, diabetes and hypertension, which I already mentioned, had higher demand from men. We also had a number of youth-specific outreach, including youth-led planning and health fair activities for youth at the campaigns, as well as youth peer advocates at linkage stations. What else have we learned? We've learned that how we deliver care matters. So we saw profound impacts of the intervention versus the control on mortality, TB, and NCD control. Many of these impacts were among HIV-positive individuals who had low CD4 counts at baseline. So they tested HIV positive in both arms, and they were eligible for immediate ART in both arms. However, only in the intervention arm did they receive the streamlined patient-centered care delivery. So what were key components of that care model? First, in terms of linkage, we aimed to collapse the care cascade. So again, eliminating delays between HIV diagnosis and treatment. We provided transport vouchers from the first visit. We provided same or next day clinic visits for ART start. And we incorporated a warm handoff of the patient at time of HIV testing to clinic staff to ensure them a welcoming reception. Second, we delivered care using a patient-centered streamlined model. So some key components of this model include efficient visits for patients and staff, reducing wait time, and also providing clinic visits every 3 months rather than every 1 to 2 months, as was the norm when we started the study. We fostered a patient-friendly approach to care, so really fostering trust, connection, and a sense of investment in the patient, as well as providing flexible clinic hours to make it easier for the patient to attend. We provided a mobile phone hotline for patients to access to allow them to answer their questions and reschedule appointments. We provided appointment reminders. And finally, we incorporated viral load counseling in a structured format to discuss the results of viral load tests with patients as an adherence tool. So to conclude, what have we learned? I think we have learned a tremendous amount about one model to successfully increase knowledge of HIV status, to successfully increase viral suppression, and to save lives. So first, we worked from the beginning with the community to develop approaches that were responsive to their needs. In response to the community, we really designed an intervention that was about community health and incorporated multi-disease services. And this has really been embraced by the community, is feasible, and added value. We've learned that it's possible to reach men and test them, and that men will engage in care and retain on care and suppress if we provide services that meet their needs. Our results importantly confirm the findings of many that when you scale up ART and suppression, HIV incidence goes down. And finally, we've learned that how you deliver care matters and can save lives if it's done in a patient-responsive way. Clearly, there's much work to be done, and so I think, just in conclusion, in particular, there's work to be done developing new approaches that work better for youth, new approaches that work better for testing and suppressing mobile populations and in-migrants. And then finally, as HIV incidence falls, improving our understanding of the ongoing drivers of new infections and who remains at risk, and using that knowledge to really effectively and efficiently target ongoing testing and care services. So much learned, much work to do, and again, I want to thank the organizers.
Thank you so much. We now have about 5 minutes for discussion and dialogue and questions, and I wanted to ask Dr. Moore if there's any data from the BCPP about tuberculosis incidence or overall mortality as was seen in SEARCH, and I know that it was a very different design, but those were some of the very exciting results from SEARCH.
We are just beginning to look at our mortality data and analyze that. So we do have information on it. We have not thoroughly analyzed that yet.
No TB data?
Pardon?
Do you have data on tuberculosis?
We do have data on tuberculosis.
Yes.
Yeah, hi, I'm Steve Smith from South Africa. I hope you're not going to give me the same answer, that you have data but you haven't finished the analysis. For both of you, my main question is about cost. Cost effectiveness, what data you have, what analysis you've done, or when you intend to have it for either whole intervention or more even usefully specific components of the intervention. And Jan, particularly for the track and trace, if you could maybe comment on what cadre of healthcare workers actually were effective in doing that? Was it sort of a lay worker or a more expensive, more trained worker? And your intervention would only work with the unique ID and other information systems. Did you have to enhance those first, or were they actually already something you could work on and then do the rest of your intervention? And for Maya, the after hours, how widespread, and again, what were the operational and cost implications of that part?
Okay, I'll start if I can remember the questions. In terms of costing, Harvard School of Public Health was our partner in this, and they're doing a very large costing study and a cost effectiveness study. And I can't really speak to when, but we're looking. We have already started, just from an intervention standpoint, looking at the costing of home and mobile testing in the community. And hopefully that will be out fairly soon, because I know that is a big issue. Your second question was about tracking and tracing. Tracking and tracing, we used community counselors, health workers to do some of it. For the in the clinic, we used primarily the nurse prescriber to try to contact people through phones and to deal with other clinics. So it was, we put additional person into the clinic, but primarily that was for research purposes and to keep up with our data, etc. We use the clinics as the government clinics. We use the government electronic medical record, and the OMONG was something that was already a part of the national plan. Now, did we have to do some things to improve the quality of the data coming from that? Yes, we did. And that's something that took substantial resources. Of course, we were also trying to have research level data, so you have to also take that into account.
Thanks very much. So first of all, in terms of after hours and how widespread they were, I will say that they were used in many places, and just talking to both clients and providers, many people spoke to the importance of this in allowing them to access care. In terms of cost, we have published on cost for both the testing approach and the care approach. For the testing approach, the cost is in line with other approaches, particularly when you take into account the coverage achieved. And importantly, adding on hypertension diabetes screening added only $1. So it was very cost effective. In terms of the streamlined care approach, costs for that are also very similar to costs of other program costs that have been published. And then finally, I might just note that Search also had unique identifiers and did linkage tracing, and so I think it's really exciting as we move forward, thinking about learning about the commonalities of what really works.
Great. Is there a question in the back?
Yes, Simon Aguilera, CDC Zambia. My question is to Maya. Can you tell us why the viral load suppression among youth is lower, especially since the intervention communities, more than 90% know their status? So why is it that the youth, the viral load suppression is low? Is it that they were not getting started on treatment, or they were not adhering to treatment? And can that explain the reason that the drop in incidence is lower? The overall drop in incidence is lower. And I suppose that will also apply to Jane in Botswana, since your incidence was still about 6.9, annualized incidence was 0.6, right? So still.
So to make sure I understood the question, so first of all, in terms of testing, we were very successful in reaching men. But as you know, we were slightly lower in terms of the overall suppression achieved at year 3. And so I think there's about a 7% residual difference between the women and the men. And
Well,
that's
more specifically among the youth, I think it was.
Oh, the youth. I'm sorry, I didn't hear your question. The youth, absolutely. Yeah, absolutely. So I think there's two big issues, well, several issues with youth. One is that we certainly need care programs that respond more to their needs. So absolutely part of that is driven by lower retention once they've linked to care and initiated, and lower suppression. The other piece of it is that the youth are obviously also at the greatest risk of new infections. And so when we look at population-based snapshots and not just cohorts over time, that also, the new infections among youth also drive that number down. So I guess the short answer is both. We need, I think, efficient, focused approaches for testing youth probably more often, and we also need better approaches for responding to their needs and delivering care so that they can achieve and maintain suppression.
Thank you so much. I would like to ask anyone else with comments to wait for the open discussion at the end, because the next topic area is a very important one, and the speaker will be Iris Samini, who's the Senior Advisor for Health Economics at UNAIDS, and she's going to be talking about structural barriers, and more specifically, user fees, false economies, and inequities in the AIDS response, and how they can be barriers to effective programming.
Thank you. Hello, everyone. I will speak about structural barriers, but as we said, we're going to focus mostly on user fees, knowing that this is not the only structural barriers. But before we go there, first I would like to thank Ambassador Burks for giving us the opportunity and pushing boundaries on the issue to be placed at a higher level forum of discussions, which until now is really controversial. I believe you haven't seen many presentations at the AIDS conference about this until now. So the presentation is a bit longer because it has 3 layers. One is why are user fees a structural barrier for accessing HIV services? The second is, can we do something about user fees? I mean, what's the evidence until now? And the third part is looking at how we can approach it from the access of HIV and health services in key priority countries. So some of the slides I'll go through, you're going to have access. Please feel free to consult, but I want to get to the end of it in terms of next steps within time. Structural barriers and access to services was the center of the UNAIDS report as well, that was launched recently, for the simple reason that global targets and global results are quite impressive. We have 21 million people on treatment, but they also mask quite inequalities in terms of progress towards treatment and other targets in the regions. And if we look at the cascade of the treatment across the regions, we will see that the countries who have the highest number of structural barriers, that I'm going to come back in a second, have also the regions that are lagging behind in between the different cascade pillars and how they have progressed, in particular Middle East and North Africa. So the same if we compare Middle East and West and Central Africa. If we compare the West and Central Africa treatment transmission rate among children with West and Central Africa, East and Southern Africa, it's double. So one of the key questions is, as we're going granular with the information about who is being left behind, we also need to go granular to understand why are they left behind. And there is quite a good understanding of the structural barriers that are impeding the demand side access of services, while there is a lot of investments that are being made on the supply side, strengthening the system, lowering the drug prices, training human resources for health. But on the other side, on the demand side, those investments will be not exploited at full if we don't address the barriers. So there is a better understanding like why young women and girls are left behind, and they are very much related to gender-based violence, intimate partner violence, how stigma and discrimination can be a major effect on keeping people from treatment, in particular discriminatory laws for key populations. And we know that the report indicated that the number of new infections outside sub-Saharan Africa is not falling. And outside sub-Saharan Africa, it's mainly key population epidemic. But when we reviewed what was the perception of barriers of accessing services from people living with HIV in 22 countries, the third barrier that they mentioned is affordability. And we are not discussing what are they paying for transport or personal cost to reach the services, but we are mostly discussing here what they refer to as user fees. And user fees or user charges that are quite well known is what you pay at the point of service as an official payment required to access the service. But on the other side, it's also a bit of, as we call it, a neglected barrier because we don't speak much about it. All our efforts have been at community delivery to address transportation, community delivery, strengthen the supply system, and the barrier that stays in the middle has not been so much spoken about. There have been a lot of calls for action from people living with HIV, from NGOs on the ground like Médecins Sans Frontières, Save the Children, and there is more evidence that documents that fees are one major impediment, in particular in West and Central Africa, like the pathway of a young woman to seek testing in Cameroon, where the fees, whether at the clinical level or hospital level, will extremely discourage her. And the impact is beyond one person. It's a pregnant mother, and then we have those rates of transmission among children that are influenced. What else do people living with HIV pay? I mean, we assume and we know that ART is free of charge, and somehow this is the overall perception, so there are not other costs. But we have taken the example of what some people pay in Burundi, and this is not a unique example. There are several. I wouldn't focus on the single figures. For us, it's small. For them who are with a very low income, this might contribute, and I'll go to effect on the treatment cascade. This might contribute about 20 to 50% of household income. So if you add the level of layer of stigma, 1 in 3 people wouldn't go to seek health in health facilities because of stigma, and then the impoverishment level and inequities, we can see that user fees amplify also the level of impact of other barriers. What do we know about user fees? And this is not about HIV. This is about user fees were established in the 1987. The progress has been made. There is overall global consensus that user fees did not produce the effect that they needed to produce, neither in terms of revenue for health financing, nor in terms of reducing inequities. However, the progress of moving away from user fees is very slow. And as you see, low-income countries are the ones who are charging the most in terms of user fees at different levels. However, countries took action, and there is evidence that when appropriate policies are implemented in the right way, there is an increase of service delivery, or the service uptake, and it's sustained. And that's Uganda, that's Burkina for children under 5. And then in Jamaica, it proved also that the inequity gap between children who are poor and the children who are not poor starts narrowing after the removal of user fees. Now, many countries used the user fee removal as a method to accelerate maternal and child care because that was where we're lagging behind. And if we make our link with the initial coverage and the treatment cascade in the West and Central Africa, we saw that pediatric treatment is lagging behind. And there is longitudinal data and Cochrane analysis which shows that there is impact on increasing access to service and it's sustained. But some of the proponents of the user fees will say, well, if you remove the money at the facility level, they have nothing else to survive with. And the Malawi is the best example, is where you show that you don't need to have a well-funded, fully funded health service and very well-structured health system. It's mostly the power of policy that brings the changes. So money is important, but also the policy and the commitment. And that is one of the examples where they reduce the out-of-pocket expenditures. And this is another quote which I like it very much, because if we compare Malawi maternal child death with Nigeria, it's like the revenues are much lower in Malawi, but the indicators, it's much worse in Nigeria, which brings also the elements that it's not only about money, it's about strengthening the system and strengthening the political commitment. Same for Sierra Leone, where we saw that the under 5 mortality rate was heavily affected. And one key element, because this is the nice side of removing the user fees, but where can we fail, is with implementation. If it's not implemented well, if the revenues that are removed from the facilities are not compensated, and if the health system is not strengthened at the same time, the removal of user fee will fail. So what does it mean for HIV? There are many environments that we are navigating, and there is policy, there is politics, there is elections, there is health financing, but there is also a building momentum that we need to build on to move to country solution. And first, it started with the Médecins Sans Frontières book, a Lancet Commission production by Africa to say that we need to remove the user fees. It is in the report of UNAIDS for the first time. But what was more important is that PEPFAR put it so much at the center of the discussion of what's holding behind effective investment on West and Central Africa, that one state in Nigeria published an article saying, PEPFAR COP said user fees are a barrier, I'm acting to remove user fees. So it's the power of political collective commitment that makes the change. We have the argument, it's what we call, the economists call false economy. If you have an infectious disease, the rapid scale up is what makes a difference. So whatever you're delaying in terms of access to services, it's costing to the society in terms of human capital, budget, treatment, far more than the revenues that are coming. So the issues, the specific case of HIV is, first, it's a false economy because time is of the essence. Second is because there are externalities with the infectious diseases. You have more benefit by testing than simply testing for HIV, which are not usually captured on those analyses. So what can we move ahead with some ideas and some suggestions? And I'm on the last 2 slides because I got a stop sign. So first is, we cannot resolve the issue of user fees if it's not addressed within the context of health financing strategies and progress towards universal health coverage. In the meantime, countries have not waited, so there is room to look at country-designed mechanisms that address the three elements. Where are the priority areas? And we need the data for that. How can we offset the loss of revenues by facilitating increased budget? And strengthen health service quality and supply at the same time. So if we take one priority area, let's say in Cameroon, where we're strengthening the supply side with results-based financing, then the donors on the other side can increase the community demand. So the matching on those high burden areas will improve access and acceleration. And that's the type of analysis that we can do by service, by geographic area, by population. We need the data because we don't have enough data. But what is interesting with RBF is that in Cameroon didn't specifically increase ANC demand, but it did have an impact on reducing informal and formal user fees. So if we as a partners have a role in mobilizing community, increasing demand, and the other part of the donor can compensate and strengthen the health system, it's the synergy. And these are acknowledgements to my colleagues who have worked together to prepare this. But more important is that the same model that we used in AIDS response, community which is vibrant, strong voice by people living with HIV, strong investment by donors, and then political leadership can be translated at a country-level model that finds those mechanisms. And we can start with one or two countries, I believe, in a near future. Thank you.
Thank you very much. We have about 12 minutes left, so I'm going to ask if there's any comments or questions about the latest talk, and then we can just open it up to get questions or comments about any of the topics that we had. We may be facing the attrition factor of the late afternoon. I want to congratulate you for doing a 30-slide talk in 12 minutes. That was very impressive. Do you think that UNAIDS might come and do some technical assistance with the United States to eliminate some of the cost barriers to effective health care and treatment, not only for people with HIV, but, are you going to answer on behalf of the U.S. government, Andrew?
I'm here to ask a question, thanks.
Okay. All right, Andrew.
Great. Hi, Andrew Forsyth from SCAC. Iris, thanks for a really provocative presentation. I heard you say that, well, two things. I heard you say that Nigeria was working to eliminate user fees, formal and informal fees. I chatted with some of our in-country partners this morning, and it doesn't sound as if there's that much progress taking place there. I wonder if there are other examples beyond Cameroon, perhaps, that we might look to for leadership here, or just as examples for how to do this. Maya and Jan, a quick question for you. I want to go back to the question that I think Steve was asking, and that was, you guys had these very large combination prevention trials, and a question I have is, what are the key components there? If we can't do everything, if you were to consider or rank the components that account for most of the variability in incidence reduction, mortality, aside from treatment itself, what would those be? And then finally, I just want to go back to you for a second, Andrew, and just say, we heard about two models this week, one by the CPAC model, some analysis that you and your colleagues have done. Both seem to offer a pretty compelling case that TLD has many strengths and worth considering going forward with. I just want to hear any comparison that you have between the model that you presented and the one that we heard earlier today from CPAC.
So this is like the rush of 30 slides in 12 minutes. Nigeria is not working on removing user fees specifically. This was a special case of a state that took the PEPFAR comments very seriously, and it was just to illustrate how political commitment sometimes is enough to make the change. The countries that are working, I think DRC has a good example. During Ebola, they removed user fees in Likati, and they had an increased impact on access. But the best case that we have seen so far, where it is in terms of HIV in West and Central Africa, is the Burundi example. And we are thinking of documenting with partners the example of Burundi, because they have a mechanism, not only one donor that provides money to one center, they have a coordinated donor mechanism where they have mapped the country geographically and seen the added value of the different interventions. So I think those are the examples. Then the other examples are mostly related to maternal care, child care, rather than HIV. And we talk a lot about Western Central Africa, but there is a lot of a cry for help in Eastern Southern Africa as well in terms of the cost of CD4 and other tests. So there are plenty of examples that we might have to do a publication to show how this varies.
Great. So in terms of key components, I think clearly the streamlined patient care delivery system we used was a key component in our health outcomes. Again, we saw significant differences between the intervention and the control, including among individuals who were tested HIV positive in both arms and were low CD4 and eligible for ART in both arms. And so really differed in the delivery of the care model. And so I think that's an important insight. I think we've shown one model for very effectively testing entire populations and for ramping up viral suppression very fast. So we went from 42% to approaching the 73% target within a year using that model. So I think that is also a very effective approach. I think the additional annual population-based campaigns did not appear to contribute to additional reductions in HIV incidence. And I think moving forward, a very exciting area as we think about the next steps towards continuing to drive down HIV incidence, move towards ending HIV, are smarter ways of using data to effectively design testing services and deploy them more efficiently.
Botswana is a country where you're really trying to mop up and get the last group of people. And I think kind of an attitude that you have to find everybody, and you can't lose anybody once you find them. And you tracking, I'll go back to that, tracing people, and making sure that you keep up with them, that the healthcare system knows that's what you're trying to do, that you bring your data in and say, gosh, guys, what happened? We've lost a lot of people. Where did they go? So I think in a situation, and lots of countries are going to be in this situation soon, that Botswana is in, where you're really, you're trying to get to 95, and you cannot lose anyone. You can't fail to find anyone. And I think in that situation, a tracking and tracing system may be worth what you need to put into it.
So on the, thanks for the question, comparing with the modelling presented by the CPAC group yesterday. So my first comment is that that's extremely nice work I think was very nicely done with a similar kind of model, an individual-based model, and qualitatively, as you said, the modelling results seem to be showing is qualitatively similar. A couple of points that I would make about differences with our model compared with how I understand that to have been done is that we're considering the population and considering the current, we're trying to understand as much as possible about the current population and including the fact, particularly sort of outside South Africa where viral load monitoring is not done so much and maybe switching to second line is not done so rapidly. The fact that there must be a substantial minority of people currently failing efavirenz-based regimens with drug resistance. A policy of giving dolutegravir, of substituting efavirenz for dolutegravir would, the substantial evidence that in most people that would be very effective. There are issues about people that have got resistance to their current nucleosides, and we have looked at that in a sensitivity analysis and how bad that would have to be. But I won't go into detail about that. But so I think that we're estimating a larger benefit of dolutegravir compared with the impression I was getting from the CPAC modelling, and we're taking into account explicitly the fact that there is this data, which I don't think the CPAC modelling was again, that there is this data showing a substantially lower risk of resistance with dolutegravir. So in situations where people are unable to be monitored because it's not there, it's just far more robust to be a drug for people to be kind of left with unaccompanied, so to speak. And the other difference is that we've looked over a 20-year time horizon, and they were looking over a 5-year time horizon. But basically, I think that you know, as I said, I think they did a very nice job, and we're essentially reaching a similar conclusion.
Thank you, Andrew. I wanted to close the panel by, as we opened it, with two questions for Dr. Birks. The first was that at one of the presentations on the dolutegravir NTD issue yesterday, Susan Little said that this may not just be about data and policy, it also might be about empowering women to make choices. And so what is PEPFAR and its partners going to do to let women make the appropriate choice when we've seen some of the costs and consequences of either switching or not switching? And the second question is about, we've seen very impressive results from some of the PEPFAR-supported implementation science, very big operational research programs that have been presented here and elsewhere. What's next for PEPFAR and implementation science in the next 5 to 10 years? Yeah, but I want to give Dr. Birks a chance to respond to those two, and yes.
Thanks, Heather Menzies from CDC Tanzania. My question is primarily for Maya, for the search trial, but others might have thoughts as well. In terms of the approach that brings together NCDs and HIV service delivery, I was wondering if you encountered or had thoughts about what might be some structural barriers to really doing that in a programmatic setting, so outside of the context of a trial or of a funded study, whether some of your experience either can help inform that, or whether you think there are some fundamental challenges in terms of kind of bringing together what are really potentially different parts of the health delivery systems that are potentially having different vertical funding and different ways of bringing service delivery to the table. Thanks.
Thanks very much for that question. So I think importantly, care in the search study was delivered through government clinics. And so the co-location of services for hypertension and diabetes care with HIV care was done within the existing health system. We also, I think, are learning a lot about the profound impacts that can have, not just on improving NCD care, but really in terms of reframing how people think about HIV, reducing stigma, and improving outcomes for both disease through these sort of synergistic effects. So I think there's actually a lot of potential for moving forward outside of a research study of integrating both HIV and NCD care services. And in fact, search was pretty close to the real world, I would say.
Thank you so much.
So quickly, so you're hearing my opinion, not the U.S. government's opinion on this. So I call your attention to the FIAs that have been done, because if you look at what Namibia did just in 2 years, they got the same testing, treatment, and viral load suppression as these studies. These 3 studies together, PopArt, Search, and the BCPP, cost more than all the FIAs put together. Yet, we end up with the same analyses and outcomes. So I think we have to re-look at how we invest and what we're investing in. Now, implementation science, we've invested additional funding to NIH through the networks, but through the networks for strictly indigenous generated and led in implementation science. I think, we're making a big push for country-led and country-funded, directly country-funded research. And so we're working very hard on that, and we think that's we want to be consistent in our policies. The closing comment, this decrease in TB mortality that we saw initially in the HPTN study, we're seeing in these studies, I think as we go into the high-level meeting, we have to remember that we can decrease TB expression of TB disease, symptomatic disease, by almost 65% by treating people early. So it's really, all of these pieces are coming together, I think, in a definitive way to show the impact of early treatment and HIV services.
And how can we support women to make informed and empowered decisions about their own health and that
Yeah, so that's very important to me. I think you saw it in the Jonathan Mann lecture that we should have been working on treatment literacy all along with all of our clients. Because this isn't the only potential side effect. Lots of our drugs have side effects, and I don't think anyone was, I won't say anyone, we probably didn't adequately counsel on ephedrine side effects in general, and I think what we're going to be doing now is meeting with the community groups to work on tools for designing that dialogue. Two options. One, if there's no effect, because now we're going to have to reverse a lot of things that have gone out there without a data evidence. And the other one is if there is effect, how we work with communities for that risk-benefit ratio. So we're going to be working on that right now with the communities, and then we'll bring in the government.
Thank you so much, and a big thanks to all our speakers, to the participants. I want to thank these are very large studies, and so I want to thank the communities and all of the staff that worked on these very impressive studies, and I want to thank all of you for staying until 6 o'clock. And enjoy the rest of the conference. And thank you again to PEPFAR for organizing.